a lot of wonderful molecules have come in. It started off with ARNI in 2014, along with the introduction of empagliflozin in 2014. Then the GLP-1 receptor analogs, followed by Finrinone, and now the tirzepatide. These are wonderful group of drugs which came in the last decade, significantly changed the therapeutic sky. All produces great benefits in those diseases where we considered when there was no much therapeutic option. And the last one is Finrinone. I'm sure all the pharmacology, the pharmacodynamics, pharmacokinetics, the data, everything is now clear with the discussion by our Dr. Vipin and Dr. Suraj, because these two diseases are the most important. Diabetes, kidney disease, but they all die because of cardiac disease. So whether a drug that is introduced into this cardiac kidney metabolic forum or cardiac kidney metabolic disease, whether it can produce a cardiovascular benefit, that is the first key question the world asks. Unless and until it produces a reduction in the cardiovascular outcome, it's not going to increase the life of the patients. It's not going to give a benefit in terms of reduction in significant cardiovascular morbidity. So this is a drug basically introduced for diabetic kidney disease, proteinuria, prevention of renal disease progression. But they accidentally found, because it was included as one of the endpoints, they found a significant reduction in the cardiovascular endpoints. And this cardiovascular endpoints is really something that kills. And if you look at the albumin-creatinine ratio, I think now it's a marker of vascular toxicity or vascular damage due to the long-term metabolic problems. Once the patient develops urine albumin-creatinine or increased urine albumin-creatinine ratio more than of 30, that means he is at high risk of vascular disease, vascular problems, cardiac death, heart failure, and of course, renal endpoints. Can see those patients with different levels of urine albumin creatinine ratio at various levels. As the magnitude of the urine albumin creatinine ratio increases, their cardiovascular problem increases. And all these data have been well discussed. The Figaro DKD primary cardiovascular outcomes and the combined analysis of the Figaro DKD and the Fidelio, which is the fidelity data. So I may discuss only a few things about it. So what happens in the primary cardiovascular outcome? You can see, all right. Can see what happens to the curve. The curve starts separating a little longer, not like SGLT2 inhibitors. SGLT2 inhibitors, the curve starts separating here in heart failure. In 14 days, in 28 days for the agents. But here you can see it goes on, and at 24 months only the curve started separating. And once it starts separating, then it is continuously diverging, and the divergence is more. What happened? Right, okay. So there's a 13% reduction in the primary cardiovascular outcomes in patient. There was no problem. Okay. And in the Figaro cardiovascular benefit outcomes, this was primarily driven by a reduction in the heart failure. So what's happening is the death, the all-cause death and the cardiovascular death decreases as a combined endpoint, but this predominant reduction is heart failure, reduction in the heart failure. And when we look at the fidelity data and the Fidelio DKD, there were only few patients, less than 10% patients who were initially diagnosed to have heart failure. Even now, we don't have a data with Finrinone in heart failure and reduced ejection fraction. We have data only in heart failure and preserved ejection fraction. And what they found is that it could produce a reduction in the cardiovascular death and total heart failure hospitalization. That's by 18%. And a 21% reduction in the total heart failure hospitalization and a close to 20% reduction in the combined endpoint. This also is predominantly driven by a reduction in the heart failure hospitalization. And the Figaro, one more thing is the new onset heart failure. There is a crosstalk between the kidney and the heart. Those patients with acute and chronic heart failure, they develop kidney disease, the type 1 and 2 the cardiorenal syndrome. And those patients with acute and chronic kidney failure, they develop heart failure. That's the type 3 and 4 cardiorenal syndrome, and a systemic disease affecting both these, heart and kidney, in cardiorenal syndrome 5. So this is the common story of heart failure as well as the CKD patients. They, kidney and heart, interacts each other, and cardiologists have the problem. Once the kidney develops an issue, we are restricted. We are restricted because many of the drugs cannot be given, and the drugs can produce, as he said, Dr. Suraj said, we are all creatinocentric. A small rise in the creatinine, people will not tolerate, and many of the attending physicians are also afraid of this creatinine increase. But this drug and many other drugs used in heart failure, because of its hemodynamic effect and reduction in intraglomerular pressure, during the early part, it may produce an increase in the creatinine, but usually it settles off and the long-term outcome is improved. There's a last trial, that is a fine arts trial, large, big trial, 19,000 patients. They found there is a benefit in terms of all the cardiovascular endpoints in patients with diabetic kidney disease, pre-specified cardiovascular and kidney endpoints across the spectrum of cardiovascular or cardio-kidney metabolic disease. So in heart patients with CKD and type 2 diabetes, to reduce the heart failure hospitalization, it's guideline recommended 2 drugs, SGLT2 inhibitors, and now it's Finrenone also in those patients with significant proteinuria or a reduction in eGFR up to 25. So Finrenone is recently recommended by the European Society of Cardiology in 2023 for the type 2 diabetes, CKD, hypertension, and eGFR of more than 25 ml per minute per 1.73 meter square, and a potassium of less than 5. All the guidelines and how to start, how to initiate, how to escalate, how to discontinue, all these things have been well discussed. So it's a class 1 indication with a level of evidence A. I'll show a case. 69-year-old male, diabetic for 15 years. He has CAD. We did angioplasty in 2010, that's 15 years ago, quite active and asymptomatic. Of late, he has noticed frothy urine. Somehow, I think people have cultivated, maybe due to the lot of advertisements they are seeing regarding frothy urine. Everybody has frothy urine. So, a lot of people are coming, sir, I have frothy urine, I have to look at my renal function, no edema. He is already on clopidogrel, beta blocker, rosuvastatin plus ezetimibe, telmisartan, empagliflozin, and insulin. And this is an investigation. Gross albuminuria, suspected cellulitis, systemic venous pressure normal, the JVP is normal, the chest is clear, and the urine albumin creatinine ratio is 3,352. The diabetic trials, they have used up to 5 grams of proteinuria, isn't it, Suraj? That's what's the cutoff. They have used gross albuminuria up to 5. And the echocardiography, fair LV systolic function, the LV filling pressure was normal. This patient, how to manage? Now there is no confusion. This patient, we have to add Finrenone if the potassium is normal. The potassium was 4.6. We started on Finrenone, and after 4 weeks, the potassium was 4.9, creatinine 1.4. We increased the Finrenone to 20 milligram. And you see, this is one thing I have observed. I don't know whether Vipin and Suraj will share the same thing. There are hyper responders, there are normal responders, there are no responders, non-responders. 1/3 of the patient responds in the standard fashion, 30% reduction in the albuminuria in 4 weeks. Certain people's dramatic reduction, his albuminuria came down to 845 in a short span of time. He is on all the 3 drugs which produces which is used for the treatment of albuminuria. Case 2, this guy is a mild LV systolic dysfunction, diabetic nephropathy, non-chronic kidney disease. He has anemia and heart failure with reduced ejection fraction worsening. We don't have an indication for Finrenone in this patient for heart failure and reduced ejection fraction. For heart failure and preserved ejection fraction, there is a data. Heart failure and reduced ejection fraction, there is no data, but we have data with aldactone, which I am not sure whether we can extrapolate it into Finrenone also. Here also, the urine albumin creatinine ratio is 4,356. and the potassium is normal, the creatinine is only 1.3. These are patients who are going to benefit from aggressive treatment of proteinuria. So he is on all the drugs. He is on losartan. We put him on losartan. He is multiple diuretics because of his edema. Then we put him on Finrinon and dapagliflozin. So we are waiting to see whether his proteinuria will come down. So my take-home message will be urine albumin creatinine ratio is one investigation we should never miss. We have never focused on this investigation, but now any diabetic patient, long-term or short-term, I think every year I will hear it from Dr. Vipin whether we have to do it every year. And one thing is the recommendation of European societies, you do urine albumin creatinine ratio, then confirm it after 4 weeks, a second set of examination. Not just that, if you see the first set, because albuminuria can be produced by a lot of other things also. You see albuminuria 40, immediately there is no need to jump to start Finrinon. Correct the correctable factors, reevaluate after 4 weeks with another set of urine albumin creatinine ratio. If it is persistently high, he requires treatment. I request the most aggressive treatment to prevent the renal damage, because many a times they come with a normal creatinine level. And so it plays a central role in assessing the risk of cardiovascular morbidity and mortality. And diabetics with a diabetic kidney disease or plus or minus urine albumin creatinine ratio elevation with a normal GFR or a decreased GFR up to 25 benefits from Finrinon. This is in terms of cardiovascular endpoints or renal endpoints. Urine albumin creatinine ratio, eGFR, and potassium. These are the three parameters you have to look at. And with these parameters are sufficient to initiate, escalate, and maintain Finrinon to derive the benefits provided by the drug. Thank you so much. Oh, I'm also the moderator. Can I have both the speakers on the stage so we can have, if there are any questions, please ask so that we can generate a discussion on this wonderful molecule. And I'm sure a lot of trials are on the way in many aspects of renal disease and cardiovascular disease. There is some data on, I skipped those data. There are data on patients with left ventricular hypertrophy. These are all sub-analysis of the Figaro and Fidelio group of trials, a large set of population they have. How many of you regularly practice urine albumin creatinine ratio in all your diabetic patients? Your sir does it. So, Dr. Suraj, what do you think? What is the frequency of urine albumin creatinine ratio? A diabetic patient coming for the first time. Both of you.
Okay, so whenever a patient with type 2 diabetes mellitus come to the OPD for the first time, we will do the urine albumin creatinine ratio. So as discussed, there are multiple factors which are contributing towards urine albumin creatinine ratio. So if it is on the higher side, if the patient is having uncontrolled diabetes mellitus, we will try to control diabetes mellitus and repeat urine albumin creatinine ratio maybe 1 month later. And if it is still on the higher side, will be definitely with hypertension history, AC inhibitor will be first drug to be started. Then depending upon the further values, we will be going with Finrinon. But if it is negative, generally the urine albumin creatinine ratio is recommended on an annual basis.
It's not only the urine ACR, you need to get a total urine routine also, because sometimes it can be a non-diabetic kidney disease as well. So we need to look at sediments and other factors also.
Actually, because we face this problem, I do UACR regularly, at least once a year. And sometimes, like you said, sometimes you have to repeat it. Creatinine is fairly okay. But lots of these patients, the SGLT2 inhibitors are started by GPs these days. They don't even wait for consultants, They're already on that. And like you said, if it's hyperglycemia is uncontrolled, I agree that we have to wait for it. But we may not always get it in that combination in which you get a perfectly controlled, diabetic control, and the patient is off SGLT-TR, and then the patient has no sepsis, patient has not exercised. All these are, variables. So variables are a major issue. And I think UACR ideally should be done early morning sample before anything else. Am I right?
What is the connection between this frothy urine and proteinuria? Everybody comes and tells it is frothy. I tried to find out what is. I think everybody's urine is frothy if you forcefully pass the urine into the closet.
I think if the urine is here, we can get it done. If they're still suspicious,
but-
get a 24-hour
Right.
urine
Is it
protein.
a real? Is it a real fact that proteinuria produces a frothy urine?
Proteinuria
Glycosuria
does
also
produce.
should produce a frothy urine.
So
It's a very, very common complaint now. People comes with these things, sir. My urine is frothy. Do something about it.
Yes, sir. So as you said, there are multiple reasons for frothy urine. So one of the most common thing is proteinuria itself. So any patient you ask, when they develop proteinuria, their frothiness increased. That's one thing. But when a patient comes with frothy urine, you should also do the urine routine to look for any infection, and also see what are the blood sugar value, because all these can produce, as you said, frothy urine. So frothy urine is a vague term, but when we educate the patient regarding the development of early signs of kidney disease, so frothy urine as well as edema of the legs are the two important things that we will tell also.
If it is persisting after flushing, then it is important.
Yeah.
If it goes off,
It's after
flush-
flushing it persists. That I think that's an important point, because we have seen people complaining of frothy urine even when there is no proteinuria. Yes, sir. No, not at all. If you look at these three molecules, eplerenone is a weak molecule. Spironolactone is a very potent molecule. And finrenone is in between spironolactone and eplerenone. But the advantage of finrenone is there is no hormonal side effects. We are usually forced to stop the spironolactone in at least 20% of cases. I have seen it in, when I said that it is 20%, many people are it's only in 5 to 6%. For males, the painful gynecomastia incidence is, anyway, it should be between 5 and 10%. And that is the most important reason for discontinuation. That is not there with the finrenone. Then the second question, that's the most important question. Finrenone is expensive, aldactone is less expensive. No, maybe 90% of the patient may not develop this problem. So can we use a pocket-friendly drug instead of a pocket-toxic drug? We cannot extrapolate right now because there is no comparative data on the similar group of population where finrenone was tried versus spironolactone. And the spironolactone, and the problem is spironolactone's metabolites are also equally powerful and they stay for a week. So whether spironolactone versus finrenone, can we extrapolate? I do not know. I think Suraj.
there was a study with the finrenone regarding this proteinuria reduction, but then they had a very large number of discontinuation. I think to the tune of almost 60% because they developed hyperkalemia and everything. So that is not there with finrenone. And another thing is spironolactone. The indication is very clear for hypertension, resistant, uncontrolled. Spironolactone is the drug of choice. There is no second questions about it. But if they have significant proteinuria, their BP is well controlled, then finrenone is the drug of choice right now.
And for us, spironolactone is for heart failure, and reduced ejection fraction is one of the pillars of therapy. And finrenone is still not recommended or advised for that thing because of the lack of data. We are not sure because these are all similar group of drugs, similar mechanism of action. Only thing is that non-steroidal molecule, a large molecule, and the hyperkalemic chance is less. So it's more like kalemic friendly drug. So if the patient has a borderline potassium 5 and he needs a potassium sparing diuretic, I would prefer a finrenone if his pocket can afford it.
How does 10 milligram fare compared to 20?
10 milligram, it's difficult to tell because the standard treatment protocol is you start off with 10 milligram when the potassium is less than 5. And if the potassium doesn't crosses 5 after 4 weeks, you can increase it into 20 milligram. Here, one thing is very important. You have to take a clear-cut history of what the patient eats and drinks. Because this is a drug which is going to give a benefit. That should not be offset by stopping the drug because of a person who is taking 2 bananas a day and drinking a liter of coconut water. So always look at the diet. If the potassium is going borderline, for example, you start the patient on finerenone, 10 milligram, the potassium is crossing to 5.2. Still, we can continue the 10 milligram. Then ask, what is he taking? If there is a high potassium diet, restrict the potassium rich foods, then recheck the potassium. Usually we'll be able to increase the dose into 20 milligram. There is no separate analysis of 10 milligram versus 20 milligram.
If I may add on, so 10 milligram and 20 milligram cost is almost the
Cost
same.
is same.
And another thing is, we can, for a patient who develops hyperkalemia and you want to start him back on finerenone, you can even start with 5 milligram or 10 milligrams alternate days, because a lot of them do show benefit even with this dose.
I asked because I give half 20 tablet.
Oh, you want to cut the tablet?
That is not recommended by the company.
I personally am against cutting the tablets because large majority of patients, they will not find the rest of the half of the tablet where he kept it in the morning. No, it's quite practical. And half of the patient will lose it and half of the tablet will lose the potency also. These tablets are not meant for cutting, but we have cultivated the habit of cutting, and we have tablet cutters also available. If you want to cut, you should use a tablet cutter.
So one more question.
No, 20 milligram and person can take only 10 milligram. You cut, the cost comes half.
I have 3-4 patients for whom I'm doing that. That's why, because
All right,
the
all
cost
right.
factor. So my next question is, between not a CAD patient, somebody with a normal heart, diabetic CKD with proteinuria, which would you rate, and with probably mild hypertension, which one would you rate best for controlling proteinuria in the order? AC inhibitor, SGLT2, finerenone. ഏത് രീതിയിൽ ആഡ് ചെയ്യണം? That's my
Here
question.
hypertension, he has mild hypertension. No, I think I'll add a ACARB first.
So the trick is, what if the potassium is borderline? Because in one scenario, what I had to do was, I changed over from, I was giving him telmisartan. So I stopped telmisartan, I put him on cilnidipine, and then I had to add finerenone. So
That is a very difficult question, because most of the studies, it has been added on to ARB, because when the confidence 93%, even the other studies, it is an ARB. It is a standard of care plus an add-on therapy. So I think we should continue telmisartan and then try with lower dose finerenone rather than taking off
So what about
telmisartan
SGLT2?
itself.
SGLT2 also, there's a
Yeah,
risk
you can
of-
add an SGLT2, because SGLT2 has been shown to reduce the incidence of hyperkalemia.
But that confidence group data, potassium was more with the SGLT2 inhibitor combination rather than with the finerenone alone combination. The combination had a little higher, 0.25 milligram per deciliter, millimoles, milliequivalents increase in potassium. I was also surprised to see that data. Yes.
Combination was less, finerenone was high, and SGLT2 inhibitor was least.
SGLT2 inhibitor we don't expect.
So to add on to your question, this is a common scenario that we also face, because for the management of diabetes mellitus part, we'll be continuing on metformin as well as SGLT2 inhibitor. That will be continued. So the second thing is, the next drug will be added. This will be an AC inhibitor because of the hypertension, and is having data, the clear-cut indication when to start AC inhibitor, because hypertension, proteinuria, diabetes. So then we will see the patient maybe for 1 month or something. Still the proteinuria is persisting. Definitely finerenone will be added. While adding finerenone, if the patient is developing hyperkalemia, then the question is whether to reduce the dose of finerenone, stop finerenone, or reduce the dose of AC inhibitor or ARBs to get the benefit of all these things. That's still patient to patient basis. You have to manage that.
If you ask the cardiologist, if the patient is hypertensive, no doubt the first drug should be ACE inhibitor or ARB, because we have evidence of 35 years. Anti-atherosclerotic benefit, anti-heart failure benefit, and cardiovascular benefit in terms of morbidity and mortality. And second drug will be SGLT2 inhibitors, because these are all consistent result for a long period of time. Finerenone is a new molecule. Our experience with finerenone is close to 2 years. So I'll consider these two molecules, and these are cheaper molecules also. And the third drug will be finerenone. And always we have to remember the fact that in all the finerenone studies, there was baseline ACE inhibitor or ARB. That is for the basic pillar of therapy. Then SGLT2 inhibitors were not a standard of therapy at that time, so it was not there. But last, there was one data which came there, SGLT2 inhibitors were also there. And this confidence is the best data. A combination is the most powerful thing. So if possible, derive the benefits of 3 drugs together. These are the 3 pillars of therapy in albuminuria.
And the newer anti-hyperkalemic agents are coming out in a few months' time.
Yeah.
So those are very GI friendly. They don't cause the bowel necrosis and all. So in West, what they do is in such cases, they add on one of these drugs, Patiromer or the other Localma, and then they continue these drugs. So that can be done once they come into the Indian market.
And the Localma is on the way to be for the release soon. Maybe in September or August, they'll be releasing the Localma. So the sodium circonate. But then the cost is enormous. Because but that is quite, look, that's a problem. People will spend money for cosmetics, but they are not ready to spend money for tablets. Every day they'll come and ask, sir, can you reduce the dose of this drug? Can you reduce the dose of this drug? Can you reduce this drug? But they spend 4,000 rupees easily going into a restaurant for eating the drugs, the food that produces all these problems. Nobody cares. But if they have to spend 3,000 rupees on a drug which protects his kidney and heart, no, sir, it is expensive. They drink only black label or single malt whiskeys. That is for pleasure. This is for doctor's benefit. That's the problem. This is for pressure and the other is for pleasure. And people are ready to spend money for pleasure rather than for pressure.
This is an anti-fibrotic drug. So,
Yes.
any studies or anything known
Liver.
about the
I also was thinking about it because anything that reduces fibrosis in heart, vessels, kidney, it should reduce fibrosis in other areas also. And the other organ that is going to be affected is liver. There is no data, I think. But aldactone was the drug which was used for chronic liver disease when they develop ascites. That's the most potent drug they have used, and large doses up to 400 milligram. So we don't have a data on this thing. Why it should not reduce fibrosis in liver? It's a reasonable thinking. I'm sure a data will come out soon.
It is going to be a fantastic drug because the GLP-1 RA, that subgroup analysis hasn't come. So once that comes, again, it is going to be interesting. So how it is going to be. Newer trials are going on regarding non-diabetic kidney disease, the other glomerulonephritis. So it has got a long way to go.
Because one of the drug which was introduced basically to reduce triglycerides, now they have found that it reduces fibrosis in MASH, and we prescribe hardly this drug, very rarely this drug for reduction in triglyceride. But now the gastroenterologist, every patient with chronic liver disease is on this drug, saraglitazar. So the company has made a fortune. Thank you. Thank you so much. I think both the speakers have done a wonderful job and great discussion. Thank you. Thank you so much.